help moderate and facilitate some of these panels, and sometimes recruit people out. And just thrilled that over 200 people registered for this. And maybe Durhan, do you want to introduce the hour and a half and then the full series? So I'm going to go on mute, but I'll be back for panel 2. Does that work?
Yep, that would be great. Thank you. So we're going to encourage anybody, everybody else to maybe turn off your camera and mic while we're doing the first and second panels, except for the panelists, of course. And then, but definitely, as Bill says, use the chat. Maybe I will open it up with the, Angela, if you don't mind to put up the slide deck, and I'll just run through the format of what we're trying to do here. And as Bill says, we're thrilled that so many people have been able to join us and are interested. So those of you who are with us for the beginning of our consultations way back in October, which seems like it was a million years ago, really when we first started consulting on setting up the National Rare Disease Drug Strategy, following, as we said, the commitment of the federal government to put $1 billion into setting up this, this initiative for this entity. Since that time, we have been doing webinars, probably, at least a couple of months, and into January, when Health Canada also then opened up their consultations on it, and we all participated and had the opportunity to participate in those, as well as we're continuing our series. So we're really delighted that we're at the stage where we are now. We at CORD have been really trying to continue to kind of push forward in terms of the consultations. We all know that there is, in fact, an ongoing commitment. We're really thrilled that in the minister's speech in the budget, there was a recommitment to $500 million for the next year in terms of setting this up, and the ongoing commitment for $500 million a year, which is really, I think, a huge, huge commitment, but also makes it very real. What we want to do in this next series, so we've got 4 webinars that are planned, is to really talk about what should this look like? How should we be implementing this? With no guarantee that anybody's going to pick up on exactly what we're saying to be implementing it, but we do want to start to put some of those thoughts out there. And what we also want to do, though, is beginning to do some things that we can implement. There were great recommendations that came forth. I'm sure that when Health Canada puts out their consultation document, we'll see some of those additional recommendations and kind of where the trend is going in terms of consensus. But what we also know is that there are things that we can do right now. We do not have to wait for a new strategy to be implemented. We don't even have to wait for $500 million to make this happen. Not that we don't want $500 million, but there are many things that we can start to do now. And that's why we called it Jumpstart the Planning and the Implementation of the Rare Drug Strategy. And that's why we need you folks here, because what we want to do is to really have your input, to actually pick your brains, but also to have your commitment and ongoing engagement, because there are lots of things that we can do collectively to start to move into the direction of having this national program, national strategy for rare disease drugs. And also we wanted to jumpstart it because we do know that there are some really urgent issues that need to be addressed. I called this intriguingly every 18 minutes, and this wasn't just to kind of get your attention, but it was in fact trying to do that, because there was some very interesting, I think there has been some very interesting research that really shows, I don't think it's a surprise to anybody, that rare diseases are undercounted, in part because they're underdiagnosed, but also because we don't actually have diagnostic codes for many of the rare diseases. And we do know that, I mean, those of you who are much more familiar than I am with regard to hospital records and even death records, will know that oftentimes what is noted as the cause of death may be something that is very close to the cause of death, but does not necessarily address the underlying cause of death, which in many cases can be a rare disease. So there's been some great research that taken together, 5 or 6 research studies, which we have, with the help of really good researchers, extrapolated to say that, more about 20, 30, 40%, depending on whose data you're looking at, of neonatal deaths are due to rare diseases. Certainly, we recognize that many of the rare diseases, inordinately 2/3 affect children, and about half of those, will die before the age of 5. We also know that in some of the hospital studies that have been done, up to 50% of those children who die, and one study out of Ireland showing that more than almost 60% of those will be due to rare diseases, oftentimes not recognized as a rare disease. So just to say that if people are interested, we can certainly I'd love to do a whole seminar on it to really talk about diagnostics and numbers in rare diseases, but using some of the studies out of the US, out of Ireland, especially out of Western Australia, especially, is kind of where we came up with this number of 29,000 children under the age of 15 will die in Canada of a rare disease. And that does not include the pediatric cancers. Not to say that pediatric cancers are not rare diseases, not to say that all rare cancers are not rare diseases, but even if we take out that group, we will recognize that about 29,000 children under the age of 15. So this is something that is a significant number, and why we in the rare disease community say rare diseases is actually a public health issue, and part of our goal actually, and I think that hopefully, Hamira will be able to talk to that a bit from the point of view of some of the work they're doing on newborn screening, is that what we need to do is a much better job in terms of diagnosis, so that we do get these children diagnosed, we do get, rare diseases identified, and we do get a proper accounting of the impact of rare disease. So I didn't want to go into that too much, but I have had lots of requests as to where does this number come from. Anybody who wants to, certainly I'm happy to pass to you the research that we draw this from, and certainly to walk through or to share with you some of the calculations that have led us to make what seems to be a very extraordinary set of statistics, and that is 29,000 deaths a year, which translates, if one does the math, about one child under the age of 15 dying of a rare disease every 18 minutes. And as I say, the sad thing is that we can't prevent all of them, but we can certainly prevent a whole lot more than we are. So that's why we're wanting to use that to kind of lead into this first webinar and to this first panel. Next, Ange. So wonderful lineup for our first panel here. It's a combination of what we have in terms of patients, in terms of healthcare professionals, from the industry as well. We're just delighted that we put out the request for people to come and speak to us, certainly about their personal experience, their professional experience in terms of the importance of being able to provide therapies to children and to all patients with rare diseases, and certainly some of them not children. But there are many cases in which we have urgent needs for rare disease treatments, and not having immediate access as it's available is really, in many cases, a real challenge in terms of the ability of these patients to actually be able to benefit from it. Next slide, please. We have a second panel, which is going to give us some of the nuts and bolts of how do we make these available. And I'm really delighted to have people step forward to give us some of that information. What's happening in Health Canada. Celia is going to talk to us about a range of initiatives there. Brad, who's had experience both in the government and now with one of our leading statistical organizations, is going to talk a bit about what happens in terms of provincial access programs. We've asked Patrick Manfred to come and talk to us about what's happening in terms of Quebec, especially with regard to the passion d'exception as an option. Karen has so kindly, as she has in many, many cases, Karen Boyne from CLIA is going to talk to us hopefully about some of the initiatives that have been in place with the private drug industry and what else needs to be done as we get more of these drugs that may have some immediate application needs. And then we're delighted that Bennett's going to talk to us about what kinds of compassionate access programs the industry has. So both for those specifically, with Sanofi, but also beyond that. So we're delighted to talk about what are the mechanisms that are currently available, how well do those work, what else needs to be done. And then hopefully all of you will join us when we talk about panel 3. How do we jumpstart from here? How do we get from where we are to looking at some of the challenges in front of us, and what can we do? And I really do want to say, what can we do now? We don't have to wait until 2022. We certainly don't have to wait until a big bucket of monies are dumped in front of us in order to start some of that implementation. Next. So this is our series. So we've got today, we're going to talk about the need to jumpstart access to therapies. Next week, we have one that's going to be really honing in on some of the two most important issues that I think are for rare disease therapies, managed access schemes, and also being able to address the issue of real world evidence, real world data, which is going to be the key to actually being able to bring in these drugs in a very timely fashion, but also safe and being able to capture effectiveness and cost effectiveness. June 10th, we are going to come back to saying we call it the 5% solution. Only 5% of rare diseases actually have treatments. What do we need to do in order to make sure, number one, those therapies that are there come into Canada in a timely fashion, but also, as we've heard, what is Canada doing to actually commit to and to contribute to the research and development in terms of therapies for rare diseases? And then the last one, very, very importantly, is what do we need in terms of an infrastructure? Why do we need to build up, the clinical diagnostic, support and the research and development of portions again, in order to make sure that we are able to fulsomely address the access to therapies. Without that infrastructure, we just have drugs and not necessarily going to be benefiting anybody. And we've got some people here today who I'm really delighted, in terms of the clinical work that they're already doing, who will also, I think, we hope for maybe come back on the 17th. We'll really talk about what are the examples that we've got currently in terms of clinical infrastructure, but also then what else needs to be done. So that's it, I think. Yeah. So we are going to then move into our first panel. If I can ask again, all those who are on panel one, if you don't mind, we can turn on your screen and we will get started. Parker, and she's probably best known as the mother of Max, who is a child who was born with spinal muscular atrophy. It's a very rare disease and it weakens the muscles and it really affects the ability of the child to be able to walk and sometimes to talk. Certainly can affect their swallowing and their feeding. Just can you tell us, Barley, kind of what is it, the treatment that was available when Max was born, why he was not given treatment immediately?
Like he was born at 24 weeks, 24 and 3. And he had a few complications in the NICU, brain bleeds, normal, I will say normal, but normal things that happen to premature babies. And so he was progressing completely normally, as a preemie would. He was on oxygen for quite a while when he was at home, but we didn't really see anything that would cause alarm. And then Max's birthday showed up January 11th, 2021, and he was 2. And at that point, there was no word from the provincial government based on funding. And so we just continued to push forward with our fundraising and what we were going to do. We were really big with the advocacy. So
back up a bit. So you made an appeal to Alberta, right? Because it hadn't been, it had not yet been approved, but there was no reimbursement yet. So
there's no reimbursement.
So you make a direct appeal to the Alberta government to say, can you do this in advance? Because usually they don't, right? Usually we wait till it's gone all the way through to, getting a price negotiated, and you're saying, no, I can't wait because he's going to be 2.
Yeah, because it came up. Yeah. So we literally pushed our community, family, friends, everybody on our social media. The letter to put together, like, this needs to be funded by the provincial government, like send. And, we had a phone call from a person in the government's office saying we get 1,000 emails a day some days, from supporters of Mighty Max and whatnot saying, Alberta government, step up. What are you doing? What's going on? So finally, right at the end of January, Tyler Shandro he came on the news and he made an announcement saying this, Alberta will fund Zolgensma on a case-by-case basis. Max had that IV hooked up and infusion in. I wasn't going to stop pushing, and we weren't going to stop fundraising and things like that, because you never know. And that's kind of the scary part, is even when, they may say, yeah, no, we'll do it, and that's okay. It doesn't, it didn't make me feel any better. No weight had been lifted until that day, until his infusion day. He could not do, even before his regression, so he is trying to stand up on his own. He can, sentences together, where 2 months ago that was not a thing that he did. So the advocacy, you have to advocate for yourself and for your child in that case, but it is so hard when you have to advocate for just by yourself. And that's why it's so important to have, like court and things like that, to just help us navigate such a very frustrating system.
Sorry, that was a little bit of an abrupt ending. We actually have a much longer interview with Brierly, and just to put it in context, she was scrambling because at that time, you couldn't get the gene therapy after the infant turned 2 years old, and so she was very desperately trying to get it because there's no way that drug was going to be negotiated with a reimbursement plan before that child turns 2. So the government did step in. They made the announcement, and as you heard, they actually did treat the child. So Alberta made that happen with the support of the company who put together an early access funding program. And the same offer was made to Ontario, we believe, and there may have been, children also treated in Ontario under that basis. But as you can see, this is not the ideal way to do it. You do not need, as Brierly is saying, it's really hard in terms of being able to do that. I wonder if I could just flip to Callie Ursula, who is very kindly, I think, here with us from Manitoba, but maybe just talk a little bit about your experience.
So my husband was diagnosed with amyotrophic lateral sclerosis in the spring of 2019. And at that time, our physician said, well, there's one drug on the market that might extend your life for a couple months, so I can prescribe you that. I'm a pharmacist, and so I knew that there was another drug that was available and that had been just been approved, received its NOC from Health Canada a couple months prior. So I asked about that drug, and he was like, I don't know that you're going to be able to get that, and it could be years away before it actually is available to patients. Like, my husband has been given a 2 to 3 year prognosis. Like, if that's the case, he won't be around to access it. That was just insane to me, that in a disease where you're given that prognosis, that it would take that long to access a drug. So I went home and actually started figuring out what we would do with the rest of our lives, because we were told to go home and start checking off our bucket list. And I found out that there were some patients across Canada that were able to import a medication called Edaravone. That it was the same medication that was approved in Canada a couple months prior, but they were actually importing it. So I did approach the physician and asked again, okay, well, can you support us in importing the Edaravone? And the physician and the care team supported us, gave us the right letters that we needed. And the whole process to try and get that organized and make sure that my husband has a port or a PIC line in place, and that we're going to be administering a medication that's coming from another country, was overwhelming after being given that diagnosis. Like, I think back to that time, I don't know if I slept. I would wake up early in the morning and be emailing with Japan. And again, as a pharmacist who's used to working in the healthcare system in Canada, I couldn't believe that was what I was doing with my time. And I was worried, again, like, it's going to be coming over from a clinic in Japan. Is this going to be transported properly? Is it, I was worried about all these things because it cost us thousands of dollars to be able to purchase the Edaravone. So once that was finally in play, and I'm like money transferring to this middleman in Japan, we do get the Edaravone, and I made sure, that I talked to health inspectors and said, we're still allowed to do this, right? Because the drug is approved in Canada. Are we still going to be able to do this? And they're like, let us check into it. We'll make sure. And then they said, yes, it'll be able to be imported. And then it ends up in Vancouver. And it's sitting there, and I can watch on the tracking system that's sitting in Vancouver. It's sitting in Vancouver. And I'm like, okay, my husband has an appointment now to have this infusion. And so I ended up having to get my MP's office involved and Canada Post involved and the health inspector all had to coordinate, and we managed to get it to make it happen. But I am telling you, the amount of tears that I had over those couple of days to be able to actually get the medication. And I'm thankful that we were able to import it. Don't get me wrong, I was thankful. But the added stress when your husband's given a terminal diagnosis, it was too much for any family to have to go through. And then we were lucky enough a couple months later, just as, you know, as a comparison, we were lucky enough a couple months later to be able to access Edaravone Radicava through a special access program. And, you know, finally then I was like, oh yeah, we are Canadian. This is the way we should be getting medications. We should be able to, you know, communicate with people within Canada and have a process where, you know, you have a disease, an incurable disease, we call it the ALS clock. When you're diagnosed with ALS, you have a short period of time where you need to get that treatment in, because the ALS clock moves faster than the human clock. So once we were on this special access program, things were so much better. And I wasn't worried about importing a drug myself. I wasn't worried about how it would be stored. I wasn't worried about the infusions, because we knew we would get the medication. And so that was just such a different experience, you know, and that just goes to show that rare diseases really are overlooked. And there's no way that anyone who's been told that they have a very short lifespan should have to focus their efforts and be so stressed on top of their diagnosis.
Well, thank you very much, Callie. And we know that Callie, as well as Brierley, are remaining involved in terms of advocacy and remaining involved in terms of education. And I think that is significant, as you say. You listen to it in Callie, especially as you say, you know, you get the experience of trying to bring it in yourself and then what turns out to be the process. I'm just going to follow up then. I really appreciate both of you, both of the testimonials there. Maybe I'll just go to Mara for a second and maybe have you follow up. What is the current status, do you think, in terms of the access to treatment for SMA, and what do you think needs to happen? You know, why is this, I mean, what is the urgency at this point, and what do we need to be doing?
Thanks so much, Durhan. Thank you again, Callie, for sharing that, and for Brierley as well. I think SMA serves as a great case example and can serve as a great backdrop to this discussion. I think I should just maybe start off by saying, I think knowing the title of this webinar, and maybe this first session, looking at minutes, and then the question that you were posing around why can't we wait, really highlighting that piece around time and that urgency. And I know you mentioned it earlier, Muscular Dystrophy Canada, we're working towards newborn screening for SMA. We're talking about access to treatments, but access to an early diagnosis is critical. It goes hand in hand. This rare disease strategy for drugs is important, but we need to kind of take one step back and look at this holistic and comprehensive strategy. So looking at the example that Brierley provided, you know, Max was diagnosed at the age of 2 at the 2nd birthday. That whole situation would have looked a lot different if Max was afforded an opportunity to receive a diagnosis, whether he was preemie or not, in the NICU earlier on as part of the standard of care to offer an early diagnosis. It would have been a total different story. Even that opportunity to advocate earlier would have been better, and has potential implications on his outcomes as well. In Ontario right now, newborn screening for SMA is a reality. It's not a reality in other provinces and territories. So just wanted to start there. SMA is also a great example in that there has been some robust advancements. We have 3 therapies that are approved by Health Canada. We have a gene replacement therapy, the one that Max has access, but there's also an oral therapy that has been recently approved, and we just received CADITH recommendations for it, and Spinraza as well. This affords people the opportunity for treatment choice, and it really brings a renewed sense of hope for children, youth, adults, and family members affected. But I think what's you know, as a patient organization, what I see is that hope is then still met with a lot of anxiety of, well, when will it be reimbursed? When will I have access? You see that it can have really optimal outcomes. And sometimes even for adults, maybe the outcomes is stability and lack of, rapidly progressing in your condition. But it's met with a lot of barriers in terms of right now, Spinraza is available and reimbursed, but with the other two treatments, they are not yet available. Zolgensma is on a case-by-case consideration, and that's how Brierley accessed it for Max, and Ontario has indicated this as well. But I think this sets precedent, and we should really continue to look at these opportunities for these pathways where we can have urgent access. And I just want to mention that with therapies like gene replacement therapy, where there is an indication of best outcomes at a certain age, like 2 and under, and knowing age can be an important factor, it really highlights that importance of early access via diagnosis and early access to an opportunity to seek different treatment options.
I'm going to interrupt you here, because I know you folks have such an amazing program that you're promoting through Muscular Dystrophy Canada. So I think if I let you go on, you would give us the total solution to everything at this point. But let me just pivot then, because we've heard cases where there is timely need for access when a therapy is available. And as you say, there's still a third therapy for SMA is not available. We've got a therapy that's emerging for ALS, I think, that's coming on. And maybe given that, I'm going to pivot over to, I wanted to go to VJ very shortly, but maybe I'll pivot over to Lisa to kind of help us round out the ALS story at the moment. What is happening now with regard to access to certainly current therapy for ALS, but what are you looking at in terms of therapies coming on?
Yeah, so thanks, Durhane. Yes, we are forward-looking in the sense, and also learning from the experience that Callie spoke to in terms of what we saw over the past several years. And so we are aware of a therapy coming forward, making a new drug submission to Health Canada, likely within the next couple of months. And so the opportunity that we see is really related to reimbursement. And I think for those who are on this webinar, who have participated in other CORD webinars, that's definitely been a theme. And so we know that it can take years for PCPA and for provincial listing agreements to conclude. As Callie had identified, someone with ALS lives generally 80% of people would live for 2 to 5 years beyond their diagnosis. The average would be 3. Some people live for much longer, some people live for much less, but it does speak to the absolute urgency, and people's symptoms are progressing the entire time throughout their diagnosis. So what we would like to see is a pathway for access that gets that affordable and equitable access as close to the Health Canada approval as possible, so that you're not seeing this patchwork of, in the case of Radicava, actually, PEI has still not made their reimbursement decision. They just don't update their formularies with the regularity that we'd want to see. And provinces took, anywhere from, I think Quebec and Ontario were first, and then the others kind of slotted into place. But again, you see that somebody who's in the have province, where they've made a positive reimbursement decision, versus a have not, that disparity can't happen. And so what we would like to see is compressed and streamlined timelines for reimbursement that are equitable across the country. I think Health Canada could also further streamline its 180-day priority review window, but I think the fact is that your opportunity for access to an approved therapy in an affordable way is through your provincial or your public drug plan, and so even if we were to get the Health Canada 180-day priority review shorter, which would be ideal, you're still going to be hamstrung by the reimbursement piece that happens at the provincial level. So we will see ourselves making some recommendations specific to ALS to different decision makers along that pathway, and have been doing some consultation with the ALS community, including with Callie as well as Dr. Genge, to really highlight that clock and the urgency and the current pathway and those reimbursement details and hoops that need to be jumped through just don't suit.
Thanks a lot. And I know that for ALS, this has been a fast learning curve for you folks as well. It's one thing when you have, you're going along for many years, raising money for research, trying to get to that first therapy, and suddenly you got a first therapy and you realize this is not a miracle. We've gotten to therapy, but it isn't getting to people. And I think that's kind of where, it's really hard. And then when you see it, as you say, disparate access across a country, I mean, what do you say, right? And how do you do it? So kudos to all the work that you're doing, and certainly to people like Kelly that are staying in. So I am going to pivot over to Vijay though. And Dr. Ramaswamy, maybe if you don't mind, you know what, I forgot to introduce anybody. So if you don't mind, introduce yourself when you start. Geez, I think people kind of get it once you start talking, but I really apologize. I'm terrible in terms of logistics here. Yeah, I just get so excited when seeing people and wanting people to jump into the conversation. But Dr. Vijay Ramaswamy, maybe if you, a pediatric oncologist as well, a neuro-oncologist, if you don't mind, maybe introduce yourself, but I would like you to address the issue of what we do about, diseases for which there may be therapies, but they're not yet approved and not yet here in Canada. What's the challenge there, and what might be some solutions here? I know, and I know you and I had a great conversation about, neurofibromatosis just a bit earlier.
Yeah, so thanks, Durhane, for inviting me. This is great. So I'm Vijay. I'm one of the pediatric neuro-oncologists at the Hospital for Sick Children here in Toronto. So in pediatric oncology, it is a little bit different, but I think there's a lot of parallels with other rare diseases. And the big advantage we have in oncology is that we have very rare diseases, but we're extremely well organized, and we run trials. So we end up with new therapies and evidence. And so where our challenge is, our biggest challenge is twofold. The first, there's two classes of drugs. The first are the drugs which I think should be a no-brainer, because in Europe and the United States, there's no problem with this. But these are drugs that have an adult indication, they're approved, they're marketed. And now in children, we have data emerging. The problem with this is, and we have quite a bit of this in pediatric cancer, and this is emerging now when it's becoming more common. So the targeted therapy, for example, is approved in melanoma. You have thousands of patients being reimbursed for this medication. Yet now that we see that the drug is probably even more effective in pediatric cancers, we don't have access to it here, partly because there's no incentive and there's no real path for pharma to go through the process of getting it approved. It's just too much of a hassle. And second of all, the private insurance companies aren't reimbursing this. So the province doesn't approve it. There's exceptional access programs. They're not really helpful. They say no in this situation. You have the private drug plans which say no. It's many times the same company in the US, Canada, and Europe. In Canada, they don't pay for it. In Europe and the United States, they do. And we're left with begging the companies for managed access, which is not ideal in any way. Like they end up being quite, some of the companies are really generous. For example, Novartis is great. They're really generous. They really try to help us. They get it. But there's no incentive for them to actually get that label approved in Canada. And the process for reimbursement makes it so complex that there's no point for them to do it. The parallel for me is that not to compare ourselves to the US, but you compare ourselves to Europe, which I think has a similar, socialized system. For the most part, they are a bit two-tiered. But my colleagues in Europe can prescribe these drugs, no problem. They don't need to wait 3 weeks or 6 weeks or 6 months for their patient to get the drug. They prescribe it, they get it, no questions asked. The second group of drugs, and this is where neurofibromatosis is a great example now, are drugs where there's really good evidence. These are rare diseases where we've run trials, we have robust evidence that works. It goes to Health Canada. To be honest, Health Canada approves that they actually aren't the problem here. When they go to reimbursement, the bar that's being set to have the drug reimbursed and the evidence that they're asking for is just not practical. They're trying to apply the same rules that they do to a large randomized trial of breast cancer, and they're saying that we don't have evidence. And so there's two examples. There's one example coming up in neurofibromatosis type 1. They get a complication called plexiform neurofibromas. We have a great drug. It's called Celia. There's no adult indication, and it works wonders. I mean, patients have the clinical benefit is well over 80% of patients. These are adolescents who have these giant tumors. They have tons of pain, a lot of range of motion issues. They're able to walk again. They're able to stop. They're able to sleep again. They don't have pain. They can contribute to society. And so this is going through the process right now. And again, it'll be a good example of whether the process works. But in the United States and Europe, it was 6 months, the EMA and the FDA approved that they can prescribe that drug, no problem. And we don't have that opportunity here. We're looking earliest 2023, if it happens. There's another example called Laritractinib, which is an NTRK inhibitor. Really, it works for any tumor with an NTRK fusion in it. For some reason, the reimbursement process in Canada said brain tumors aren't included, and so we can't use it for brain tumors. It makes no sense at all. They applied a bar which isn't practical. But I think for the other rare diseases, as you have drugs coming up, I think the examples that are happening in pediatric oncology are going to be very pertinent to you in terms of how some of these decisions are so arbitrary. And the third thing I just want to mention is it's not just about drugs, it's access to technology. So a lot of our patients receive radiation therapy. And there's a type of radiation therapy called proton radiations, where basically what we can do is you can limit the field of normal brain that's getting radiation. And the IQ of these patients and the outcome for these kids is actually significantly better. So you reduce the exposure of radiation to the heart, the stomach, the thyroid, the pituitary gland. We don't have a proton facility in Canada. So right now, every time a child is diagnosed with some of our common tumors like medulloblastoma, ependymoma, these are tumors where children have long-term, are expected to have 70 to 80% long-term survivals. We need to beg the government to send them to the US for protons. Now it's changing. We're able to send patients to the US now, and it's a relatively streamlined process in Ontario, but it's problematic. You have a child with a new diagnosis of cancer. The families in Toronto, we're saying, go to the US where there's COVID everywhere and get radiated. And it's not, we have half of our patients can't go to the US because they either have complications of surgery or they need rehab, or it just doesn't fit with their family situation, which means, of course, patients with money can go to the US even if the government pays for it. Patients who don't have the resources can't go. So, but there is a push in Canada to have a proton facility, but the US probably has 100 to 200, proton centers that treat children. In Canada, we don't. So those are sort of three issues. But for me, the two big issues are we have drugs available that are marketed and there's no mechanism or incentive for pharma to actually go get it approved, and now we don't have access. And the second are new drugs, which are getting approved. The process just isn't fair. They're putting a bar which really is quite inappropriate. So.
Thank you so much. That is, as I say, there's a lot. I mean, pediatric cancers are obviously rare diseases as well, but I think some of the experiences you've had have really kind of made a big difference in terms of what we're doing. Maybe I'll pivot. It's a great point to pivot over to Keith. Keith McIntosh, who I knew in his previous life. In fact, I knew him so well that when I went to invite him to come to this, his old email came up and it bounced back and said, sorry, no such person exists. I go, oh, for goodness sakes. But Keith does exist. And maybe I just asked you to share a little bit of your story, maybe picking up on where Dr. Ramaswamy kind of went.
Well, thank you. And in fact, you covered proton, and that's something that, is close to my heart. My son and I and my wife traveled to Boston in 2017 to receive proton radiation. And at the time, the province was seemed to just beginning to streamline the approvals, but it was something that I had to learn about on my own. And it was really a question of there's a matter of urgency, because you discover the tumor, the surgery happens within a day or two, and then within a month or so, you have to begin, or you're expected to begin the next phase of treatment. And I was blessed because of the context that I had to learn and to have support and understanding what was available and filling out the forms, because it wasn't a discussion that the hospital here in Ottawa had regularly, and so I had to push a little bit for that request. They were when they made the decision, they were very helpful to get us access not only to the proton radiation but the rehab facility as well in Boston, because of complications of the surgery. So it's now Ontario has just approved or reached a final recommendation on funding proton and the next step on creating a center in Ontario. But as Dr. Ramaswamy said, there are at least 40 operating facilities in across the U.S. and we're still waiting to build one Ontario. So it's and about half of the provinces do refer, and half are considering on a case, or considering having a case by case basis. So we were lucky enough to be on Ontario, but if you're not, then you don't have that opportunity.
Yeah, thanks a lot, Keith. And again, picking up, as you say, on what Dr. Ramaswamy was talking about, I really appreciate your being able to provide a sort of a firsthand acknowledgement of those kinds of challenges. And I think what we're hearing from, everybody from Barley and Callie and Keith as well, if you're in the know, and you can push for it, and you're a bit lucky, you might be able to get access. Otherwise, for many, patients, it's not possible. Angela, I'm going to pivot to you if you don't mind. You've been so great with us in many cases, and I feel like we're flipping back and forth between diseases, but I think everybody gets that there is certainly a strong underlying thread among all of those. I'll give it to you as well. What are the challenges and what are the needs in terms of being able to get that timely access to therapies? And maybe just introduce yourself as well. Sorry about that.
That's okay. Thanks, Sirhan. So I'm Angela Genge. I am a neurologist and director of the clinical research unit at the Neuro. So we cover clinical trials across neuroscience, and I have a specific interest in ALS and bringing drugs to Canada for ALS. So the biggest challenge, and it's across all of neuroscience, most of neuroscience is rare disease. It's most people think of neuroscience as migraine, MS, and Alzheimer's, but in fact, the vast majority, well over 50% of our trials are in rare disease. And what I'm seeing from my perspective is a tremendous interest in drug development worldwide in these rare diseases, both genetic and non-genetic neurological rare diseases. And so every time there's a new technology, a new breakthrough, that gets focused on a variety of rare diseases. So ALS being probably one of the most well-known rare diseases, every time there's a new technology, currently some of the biggest developments are in using something called Aso Therapy, which is Spinraza for SMA. But there's also a tremendous amount of work being done using other DNA editing technology and RNA technology, and it's being applied to ALS. So we're in a situation where I bring in the trials into Canada, and if patients are either lucky enough to be close to here, close to Montreal, or the trial allows us to fly people in to receive their treatments in Montreal, then we really are able to offer these very new treatment strategies to Canadian patients with ALS. We don't have to do what happened when I got into this field, where not only did the trials not come in phase 1 to Canada, but the drug didn't come to Canada till all the previous work had been done. So we get trials started, we get patients on drug, and the fortunate ones that join in these clinical trials continue on the drugs through open label extensions. And we can even watch drugs go to Health Canada. And we're looking forward to some approvals there in the next couple of years for some of these novel therapies. And then we reach the point where we're able to treat only those patients who joined our clinical trials, because the gap and the timeline between the Health Canada approval and the access in individual provinces can be overwhelmingly long. I think Callie mentioned, 2 to 5 years, and here we're waiting to get a Darabone available that's already been approved. And I'm in Manitoba, I'm not in Quebec, so it's taking me longer, and I'm flying to Japan, and God knows Newfoundland patients can't get it still because it's not on the provincial formulary. And I see, and I'll use ALS as an example, but it's across multiple diseases. I see all these incredible new technologies, and some of these drugs are going to work. Some of these drugs may work better than everything we currently do. And I have incredible respect for how engaged Health Canada has become. They weren't always this way, has become in reviewing these files for rare diseases. Health Canada is not against us as a community. They're very much for us. They're very engaged in working with these usually small to medium-sized companies to get these drugs approved. And then it stops. And then the only province who gets the drug, and I apologize to all of you who don't live in Quebec right now for a lot of different reasons, mostly because our terraces are opening next week. But there's a mechanism in Quebec for getting drugs, if you can justify it, once they're approved in Health Canada, while we're waiting for the process. It's simply unfair. It's unfair that young adults with spinal muscular atrophy in Ontario have moved to Quebec to get access to Spinraza.
So maybe I'll stop you for a second then, Angela, because I'm going to pivot over to Catherine, who I think can give us a bit of that story and that experience that you're talking about in terms of getting access. And, you know, as you say, not only, fortunate for her to be in Quebec, I mean, and actually quite interesting, if we go to, as they say, the sixth game of the playoffs here, you may actually be able to have the Habs and the Maple Leafs there with a real audience. So a lot of people are very jealous in terms of being in Quebec. So we'll see if it goes to 6 games. But Catherine, maybe I'll have you jump in on what Angela and Dr. Angela was talking about there.
Sure. Well, in terms of Spinraza, I'm one of the lucky ones, being a 40-year-old SMA patient and having now been on Spinraza for a little over a year, coming up to a year and a half now. And yeah, it's absolutely unfair and disheartening to see that my compatriots in other provinces don't have the same opportunity. From my understanding of the agreement with Spinraza in Quebec through INES was that INES did end up expanding the recommendation to include all types of SMA, including adults, based on a sort of, I suppose we could call it unofficial managed agreement, managed access agreement, because every year, so every 12 months, the neurologist, the specialist has to reapply or confirm continuation of the treatment for the patient. So in my case, so far, I've been good to continue on my treatments. There is obviously always that fear a little bit that eventually we might get cut off. There is a bit of a lack of transparency in terms of how is the government using and interpreting the data and the reports, the evaluations that are provided by our healthcare practitioners, whether it's physiotherapy, occupational therapy, and neurologist assessments. There is also, I know because I've been a strong participant in my own patient-reported outcomes. I do take a lot of notes and send all of my notes to my neurologist. So I know that those patient-reported outcomes are also handed over to the government, but it's unclear how they're being used from my understanding. And in terms of the official outcome measures that are used in the evaluations, they're not always best adapted to all patients. Certainly not for patients like me who are non-ambulatory and who have pretty advanced mobility impairments. So the evaluations that are used that are based on the tests that were used in the clinical trials on children are not necessarily adapted for adults who are wheelchair bound. But, you know, in my situation, I have seen everyday life improvements that to me are meaningful. Whether or not those will be considered meaningful in the long term by the government is always kind of hanging over my head, if you will.
Yeah, thank you very much, Catherine. I appreciate it so much. And we'll come back to this topic, I think, when we talk about the managed access schemes as well, because as you say, I realize I am like double the time that we had allocated for this panel, but I cannot go without really bringing in, you know, an additional community here and what's happening. I've got Karen Monroe and I've got Phyllis who are going to talk to us about emerging therapies and what we might need to do. And certainly for a very, very important condition that is certainly very close to our hearts. So maybe I'm trying to say whether I should start with Karen or with Phyllis here to give us a little bit of an update. Karen, maybe I'll start with you. Explain to us and talk to us about, I'll let you go through the explanation in terms of the condition and what it is that is coming on board and what you hope will happen.
Sure. Yes, I'm Karen Monroe. I'm a board member with the Canadian FOP Network and vice president as well. So the disease that we deal with, FOP, is a really super duper duper rare one, sort of 1 in 2 million type of prevalence. And basically, just in short, it causes soft tissue swellings in which a piece of the tissue is becoming converted to bone. And this typically starts in children sometime between age 1 and 5, although it could be later, but that's typical. And as the lifespan continues, goes by, the person develops more and more restrictions and loss of mobility due to locked and fused joints. Associated problems including scoliosis, difficulties, it can lead to difficulties with breathing for some people, and a lifespan, you know, average lifespan around 40 some years, although with some variability. My daughter Miranda was diagnosed with this condition when she was 2 years old. Unfortunately for her, FOP led to her passing away in April 2020. What I can say though is that for the last 5 years of Miranda's life, there was so much excitement about new emerging therapies. You know, we're considerably sort of further behind than, say, SMA or, you know, some other things. But where we were at is that despite the incredible rareness of this disease, there are a number of pharmaceutical companies, including Ipsen, which Phyllis works for, which are working on developing clinical treatments for FOP. And so we're kind of looking at this and thinking, okay, you know, maybe in 5 years we'll have something. It'll be there. And you know, there a number of them are actually in active clinical testing right now, which is very exciting. But we're sitting here and we're looking from the Canadian perspective. We're looking at this and we're saying, okay, so this is such an incredibly rare disease. You know, at the present time, there's about 900 and some odd cases even known in the whole world, right? So that means a pharmaceutical company has got to spend a whole boatload of money, really, frankly, to develop a disease treatment therapy. And then, you know, there's only 900 and some odd people diagnosed with the condition. And maybe, I think in Canada, we count about 17 or 18 patients, you know. And so the big fear that we always have as the Canadian patient community is, you know, are these even going to come to Canada? I mean, you hear this talk about, you know, the government doing, you know, putting caps on what they'll pay for medications. And I'm sorry if I'm kind of behind the 8 ball on that. I haven't kept up on that in the past year, but you know, there was talk about that happening. And so the thought that goes through my mind is, okay, well, so here's this, you know, maybe a drug for FOP will be approved And it's going to be, frankly, really expensive because it was so expensive to develop and there's so few patients. Are we going to have a situation where the government says, oh, sorry, we'll only pay a maximum of X dollars for a disease? Yours is over that. Oh, well, too bad. I guess you don't get it in Canada, right? I mean, I don't know if that's a reality, but that's a fear, right? That's a fear that we have.
Well, thank you so much, Karen. And I think, as you say, it's a very, very challenging disorder. And I'm not going to ask Phyllis to give you reassurances that that's not going to happen, but maybe, Phyllis, if you don't mind, kind of introducing yourself and tell us, why is Ipsen bringing in this drug that's going to be benefiting, this handful of patients that you can probably count on your hands and toes in Canada?
Yeah, thank you, Durhan. And I'm Phyllis Iwano. I head up the Neuroscience and Rare Disease Business Unit with Ipsen, relatively new to the organization. So thank you for inviting me, and thank you to all the speakers for volunteering their stories. It really, for somebody like me, it really frames the discussion. I think I wish I could offer reassurances. I'm not able to do that. I think what I can do is provide insight into the fact that we're bringing the therapy because it's an important thing to do. It's the right thing to do for patients, and it has come out of the research ecosystem as a potential. It's not a cure. It's a potential treatment where no treatment exists. And I think there's an ethical responsibility to patients when such a thing appears to pursue it, right? And then all of the complications of rare disease come into play. The low patient numbers, the evidence burden that's required by Health Canada, the lack of clinical experts even to run the trials. Even if you can get yourself a site in Canada, you need a clinical expert who will do it. So all of these factors really increase the complexity of bringing the therapy to Canada, even if you are able, willing to pursue it from a corporate perspective and from a drug development perspective. So there are no easy answers in rare disease just because of how rare they are, and the fact that the evidence base that is required should be different than more standard conventional pharmaceuticals, and really isn't right now. So there's an opportunity there for sure.
Thanks a whole lot, Phyllis. I mean, and for those of you who know the history of this drug, it was actually developed in Canada. Clementia for many years. I mean, that's who Ipsen bought it from. And it was really a very natural progression, right? So it was actually somewhat of a repurposed drug. Clementia picked it up and said, okay, we will do. And I think we were somewhat lucky because they had a base in Montreal for, many years. They really looked for Canadian patients to be part of it. I think those patients actually end up having to go to sites in the US because we didn't actually get sites in Canada, or at least not very timely. So we're hoping, this is a made in Canada drug, Karen. So let's hope that we can end up with it being available to Canadian patients. But all the things that both of you said are certainly real challenges in terms of, even though it had its roots in Canada, maybe very challenging to get it in timely access. And again, a very progressive condition. And it will, as you say, manage some of the symptoms, but it's not going to bring back functions that you may have already lost. And I think that's something that we've all talked about. I've gone way over time in terms of what I want to do with this panel. This is amazing in terms of the stories. I'm hoping that, as we move forward, we're going to be able to take up on this. And this is maybe a natural segue, first of all, for me to thank everybody on this panel who came forth, not only with your personal stories, but your clinical expertise as well, but to really help us to kind of really understand, as we say, this is what we're fighting for. This is what we need to solve. It's not policies, and it's not kind of just, dry frameworks and analyses. These are people, these are real conditions, these are the real challenges, and we should be able to do this. Many of you are doing it in your own time and in your own lives, but we also need to do it for everybody. You cannot always, all be Callie's and Catherine's and, and Brierly's out there kind of, beating on the pavement and being able to be those kind of experts yourselves. And, Keith came from within the industry and knew how the system worked, but we can't all be that, and we shouldn't all have to be that. And I think that's the challenge. So with that, I'm going to thank the panel, wrap it up. And Bill, I'm going to turn it over to you to kind of bring it home in terms of what we have in place and, how well is it working and what else needs to happen with our group of experts.
Thanks so much, Durhan. And what an amazing kickoff to this new webinar series. Hearing from patients and clinicians and people who have had to navigate a very convoluted system And just before we get into my panel, I want to pick up quickly on I think what Karen was getting into, and that is how and why is Canada not a priority sometimes. And there's some new data that just came out of the Fraser Institute, I think last week, that shows that Canadians are getting access in terms of when these drugs are actually put on the market about 460 days after the EU or the European Union or the United States. So I think an open question for us is, why? How do we shorten that time to get faster access closer to our counterparts in Europe and the United States? And what's causing some of those hitches? And that's why this is a really great panel that we've got lined up, because in the absence of that normalized access, clinical trials and research is so important. I talked to one of the panelists just before this too, and they said, that's absolutely essential. And so we're going to look at some examples for how existing pathways can actually provide urgent access for drugs used in research. We're going to hear from a senior Health Canada leader about the expedited review pathways and special access programs, how early and emergency access programs either work or don't work, or sometimes work in the provinces. And I know this past panel, we gave some examples of where they have managed to make it through, and how Quebec's patient d'exception program is actually so exceptional. It's not just it is an exceptional patient program, but I think it's also exceptional as an access program. And I know we've got lots of people on the call who are from Quebec that can bring that forward. And we have an expert on the line who's going to join us on that one too. And then finally, we're going to hear how private drug insurance plans work to provide access to Health Canada approved medicines. So let's find out how well these pathways work from the perspectives of payers, healthcare professionals, patients, and industry. And after this panel, we're going to flip it over if we've got even 10 minutes of time, and everyone's going to be encouraged to contribute. I'm going to do my best to keep an eye on the chat to help lead this conversation as well. So I'd encourage others to participate there. If we don't get to your questions, your interventions now, Angela from Cord or somebody on the back end will be monitoring that, and we'll get in touch later. So to introduce panel 2, to talk about, and I'd like you to put on your camera and your microphone if you're on panel 2 and you're speaking. Thank you so much. To talk about special access program and expedited review pathways within Health Canada, we are very happy to welcome Dr. Celia Lorenko, Director General of Health Canada's Biologic and Radiopharmaceutical Drugs Directorate. I'm still used to calling them BGTD, but it's the BRDD. So that's the best thing about these acronyms. They often change. We'll then hear from a former senior drug plan manager, Brad Aylward, who recently joined IQVIA as Associate Principal of Real World Solutions, which is great because, Brad, we want to know how things work in the real world. So hopefully you can take us out of the other world solutions and bring us to the planet Earth. Then we're going to hear from Quebec. As we know in our reading lately regarding how the Constitution might be changed, Quebec is exceptional. So a longtime friend of mine, Patrick Manfred, who is director with TACT Public Affairs Consulting in Montreal, is going to join us for that. And once again, to help explain the private insurance industry's perspective, Cord is honored to welcome Karen Voyne, Vice President of Group Benefits and Anti-Fraud at the Canadian Life and Health Association, Insurance Association, or CLIA, as some of us like to call it. People always remind me, no, it's CLHIA. So I'll work on that. And finally, we've got Bennett Lee, Head of Market Access with Sanofi Genzyme, who can help weigh in with the industry's thoughts on compassionate access programs in particular, and perhaps on research and how that's also an important avenue because, of course, the industry has to put up the medicines to be used in research by amazing clinicians like we have on the line with Angela and her colleagues. So let's kick it off then with Dr. Celia Lorenko. Can you give us an update of what's happening in Health Canada in terms of expedited review and special access? Celia.
Absolutely. Thank you so much. It's a pleasure to be here today. And it was fascinating hearing the stories in your previous panel. Very, very compelling. So thank you for inviting me. So I'll give you an update across the life cycle. As you know, Health Canada regulates drugs for Canadians, ranging from special access for individual patients with serious and life-threatening conditions looking for access to a particular drug, to clinical trials. We also regulate clinical trials, as well as, of course, market access to products when they're ready to be launched on the market. In terms of clinical trials, we're undergoing a renewal of in terms of the special access program, starting with that, we're undergoing a renewal of the program, introducing measures to make it easier for patients and practitioners to access products, especially for repeat requests. So in the past, when there was a repeat request for a product, we always requested a rationale, a detailed rationale for why, scientific rationale for why the access for the drug was being requested. So we've eliminated that step, and for repeat requests, we're not requiring that any longer. We're also introducing more flexibility in terms of where a product can be shipped under the SAP program. It can be shipped now to community pharmacies, for example, as opposed to the hospital or to a particular clinic. And then finally, also we're allowing pre-positioning of products for diseases that are very time sensitive. So to make sure that the products are available right away when a patient needs access to a product through the SAP. So those are some highlights of what we're doing in terms of updating the special access program. We're also looking at introducing an electronic system that will make it easier for physicians to submit their requests using their iPhone, for example, as opposed to other means. So now moving on to clinical trials, we're working on introducing a renewal to our clinical trial framework. And the main objectives there is to introduce more of a risk-based approach to the regulation of clinical trials. So to reduce the burden on requirements for certain trials that are lower risk versus other trials. We're also looking to introduce a tool called terms and conditions, where if there's maybe some certain uncertainty around the drug, around the safety of the drug being tested in a clinical trial, we can introduce terms and conditions that allows the trial to continue as long as certain conditions are met. Those can be, for example, increased reporting while the trial is ongoing. And finally, looking to introduce ways to allow decentralized trials. And I think this would help, for example, for rare diseases, patients who may be in remote communities, allowing a way for these patients to be enrolled in the clinical trials and not necessarily having to travel to a major city center if they have a physician in their local community that can assist them in the clinical trials. So we're introducing these measures to try to make it easier for clinical trials to be conducted in Canada. And part of these measures as well is ensuring that we can support trials that perhaps have designs that are more complicated. For example, trials that involve multiple drugs treating multiple diseases. So that can happen in cancer, for example, with targeted therapies that might be targeting several different cancers. So allowing those types of more complex trial designs to be authorized under a single authorization. So those are some of the changes we're doing there for clinical trials. And then finally, looking at expedited pathways. So we have our traditional expedited pathway that we've had for many years, the priority review pathway that some of you have mentioned earlier, which reduces the amount of time for review from 300 days to 180 days. We also have the notice of compliance with conditions pathway, which is a 200-day review pathway. We're looking to improve that in terms of introducing the healthcare system need concept in the priority review assessment to determine if there is additional factors that we need to consider when determining whether a drug should go through the priority review process. Additionally, we have introduced recently what we call health technology assessment alignment, where we share information with CADTH and INES as early as possible in the review process, with, of course, with support from the company, with permission from the company, so that there can be earlier information exchange, so that the CADTH and INES review process around whether a drug should be reimbursed can occur sooner. rather than later. We've also started working much more with international regulators. For example, with the US FDA, we have started to review many of the drugs for oncology in parallel with the US FDA, and that does help bring products to Canada sooner, as the US market tends to be a market where companies tend to go first. It's a large market. So being able to review products in parallel with the US FDA is another initiative that we have that helps with access, and we call that our Project Orbis with the US FDA. It involves also other regulators who participate, including Australia, Switzerland, Singapore, and more recently also the UK's MHRA. They also participate in Project Orbis. And those other regulators, we also work with them under our work sharing initiative, where we parse out the submissions among these other regulators in order to increase the efficiency in which we review. And at the same time, we feel it's a win-win for companies in that they will also have access not just to the Canadian market, if the review process is positive at the end, but they will also have access to these other markets. We don't do the work sharing with the US FDA, but we do it with the other regulators that I've mentioned. And so finally, a couple more comments on initiatives that we have ongoing. We're also looking to introduce some additional changes to our regulatory framework for authorizations of drugs. It's what we call our Regulatory Innovation Initiative, or Agile Regulations Initiative, where we're looking to introduce the concept of terms and conditions. This is actually something that already exists for opioids under our regulations, but we would like to expand that to other product types. And what that will do is it will just give us more flexibility in the level of data that can be used for initial authorization versus data that can be submitted after the initial authorization. So we can use a tool of terms and conditions. And that tool, I think, would be helpful in the rare disease space, where often the data can be quite limited at first. So that's one. The other one I'd like to mention is the concept of rolling reviews. We're looking at introducing that as well. And it's an initiative that we've implemented for COVID-19 products. And we've learned quite a bit from using it in the context of COVID-19. We'd like to now move on to other areas where we can use rolling reviews. And certainly the rare disease space, I would say, especially in pediatrics, would be one where we could use that tool. It's the ability for industry to provide to us data as soon as, or much earlier in the process, as soon as that data is emerging, and let that data build as we review it until we get to a point where we have enough to reach that benefit risk assessment. Additionally, we are working on a project called our Advanced Therapeutic Products Pathway. This is the project that we have under our Regulatory Innovation Initiative, where we're addressing challenges that can occur with products that are so unique that they don't necessarily fit within our current framework. So to give you an example, for example, in the future, 3D printed organs or tissues, that would be so unique that we can't really have those types of products come in through a new drug submission. We will need to look at a different way to regulate these types of products. So we've created this pathway to be able to place these products in what we call a regulatory sandbox, where we can develop tailored requirements around these products, and still ensuring that benefits, risks are well addressed. Safety, efficacy, quality is not going to be sacrificed, of course. Right now, looking at what kinds of candidates we could place in the sandbox, we are looking through potential candidates that we could move forward in the next within this year, which we'll inform the public about. And last but not least, we also have our Office of Pediatrics and Patient Involvement. It's a small office of about 6 employees right now. We're looking to expand that office and be able to support what we call our Pediatric Drug Action Plan. And part of that action plan is a strong, first of all, having a strong focus on supporting medicines for children, access to medicines for children, having the idea of a concierge service, a single window where stakeholders, including industry, can come in and have conversations on what are the regulatory tools and pathways for bringing pediatric indications, pediatric drugs to Canada. And part of that as well is looking at introducing mandatory pediatric investigation plans. So that's a work in development that will certainly come out to the community and talk about. So I'll stop there. It's quite a lot that I've talked about, all this going on right now, also in the context of COVID. So keeping us very busy, and I'll be happy to answer questions.
That's amazing. Honestly, Celia, it sounds like you've got I don't know, I don't watch that much football or maybe hockey because the playoffs are starting, a special team, you know, at the regulatory level that is like the Austin Matthews line. You're amazing. You're going to score so many goals. The question is, what happens when you pass the puck out or the next team comes on the ice that is responsible for keeping the game going? And that's where we're going to turn to next. And I know you talked to those other teams, but I'm going to turn it to Brad and Patrick and Karen and Bennett. What does it look like coming out of Health Canada and getting into the provincial drug plans? What are the bridging opportunities before you get that letter of intent, even from the PCPA, if there is one? I don't know, Brad, do you want to start and give us a quick smattering of what you experienced in the provinces and in your time supporting on these issues?
Sure, and I really hope that the audio quality is okay, because I'm hearing choppiness, so I'm afraid it's on my end. But okay, I got a thumbs up from Bill. You know, everything that's been said in the previous panel, I would kind of acknowledge and agree with, based on my time in government and my experience working both with PCPA as well as the provincial level decision maker. I'm 3.5 years removed now from that government experience. And, you know, I don't want to say that nothing has happened, because obviously there are a lot of initiatives that are happening at various groups amongst in the entire ecosystem. You know, once something comes through Health Canada, or perhaps is being reviewed in parallel with Health Canada's reviewed by the HTA agency, despite some of the challenges and limitations, I believe that the HTA groups have in applying evidence standards that were built for very different scenarios. I think that comment absolutely resonates as well, that we're trying to apply inappropriate standards to medications where your populations and your outcomes are just not that well developed or known or statistically powered. But once it hits the provinces, I mean, that is almost certainly the major contributor as to why we're looking at 460 days longer on average to gain access as compared to the EU and the United States. Bill, your specific question was around, you know, are there bridging opportunities? Are there things that can be done by the provinces or at the payer level? I think the short answer is yes, because they're already happening, in particular in Quebec, and I'll let Patrick certainly speak more about that. But I think the rest of the country is very much behind in that regard. And the most recent example, perhaps, and the one, you know, that came up in my more recent research around Zolgensma, I think actually brings back what was old is new again, right? So, you know, from a provincial decision maker, bureaucratic standpoint, and even from an elected official standpoint, which I can't obviously speak to, you know, decisions and priorities are often made for populations, right? And it is challenging, absolutely, within kind of the purview of ministries of health. There's a lot going on, a lot of complicated things. That's not to make excuses and not to suggest that things can't be better. But it is a very complicated environment, working within or trying to carve out some space in an extremely complicated environment and ecosystem as well. Layer in COVID on top of that, and I don't want to say unprecedented, but I can't think of another word off the top of my head. there's small smatterings of policy out there. Ontario had the compassionate review policy, which really was intended to, based on kind of my understanding, deal with situations that were immediate and urgent and life-threatening or threatening to limb or organ system. But even those policy, and I tend to believe that one is unique, honestly, where it actually attempts to identify and carve out a path that's outside the typical process. But even that policy, I mean, the criteria that are required to gain access through that are extremely challenging as well. And, it's not unusual, and I can't say this for certainty, but, I've kind of understood over the years that even that policy was kind of crafted in response to an urgent situation around a drug for rare disease where, the bureaucrats were saying, well, this doesn't fit our current process. And the decision makers were saying, well, I need something to, be able to lean on in the event that these situations come up, because they will. The case-by-case approvals, and I'll just kind of pause after this and turn it over to Patrick. The case-by-case approvals that we've seen recently for Zolgensma in Alberta and in Ontario, I would suggest that they've always been there. And they've always been there and not necessarily publicly acknowledged. But health ministers, although they have their own processes and they need to seek approvals from their own masters, but health ministers generally have, by legislation or regulation, the ability to make those kinds of decisions. And I would suggest, pre-PCPA and certainly pre-CADTH, which predates my time in government, it was much more common for ministerial discretion to be applied, and we had a lot more kind of either case-by-case decisions or outside the process decisions. So CADTH and afterwards PCPA, in many ways and for many different reasons, but one of them was an attempt to kind of do away with this individual decision-making in this case-by-case kind of process. And a little insider secret sitting around the PCPA table when there was a potentially contentious file that hits the PCPA table in the early days, at least 6-7 years ago when PCPA was very new. We would ask our provincial colleagues, okay, can we say with certainty to our minister that no other province has provided case-by-case access to this medication? Because one of the previous panelists said these case-by-case approvals are precedent-setting, and they absolutely are. And although it wasn't part of the stated mandate, one of the things that PCPA as a collective had to kind of wrap itself around in the early days was to try and convince decision makers, government decision makers, elected officials and senior bureaucrats, that going outside the process doesn't really help anyone. Now, that's not just in the context of rare disease, right? That is to kind of cover all things.
Yeah.
But
Brad,
the
do
fact
you mind
that
if I just interrupt you there?
yeah.
We're running pretty short on time, as everyone knows. We're supposed to end at 2:30, but honestly, you could go on, and I'd want you to go on because you're about to go on and explain how and why PCPA works the way it does. We're going to have you back,
Yeah.
but.
Let me just quickly summarize. I think one of the previous panelists said right now advocacy and pushing for a case-by-case process is really the only thing, because it's gotten some recent traction and some visibility, that is there kind of on and off the books. Right now, that's not ideal, but it opens the doors, hopefully, for more constructive conversations, because nobody's going to want to live in the case-by-case world. Thank you, Bill. No,
that's amazing, Brad, and it's a good segue actually to Quebec and to the private payers, because when I talk about pharmacare, you think of it as one blanket that covers everyone exactly equally, but you know, in Quebec, you have these almost insurance models. You have the regular RAMQ, and then you have a separately adjudicated patient d'exception program. And then I'm going to hear from Karen about how different layers of insurance can build out and around that, and sometimes be first payer, and sometimes there are other things that are especially important for rare disease patients that can get that earlier access, because that's what we're trying to do. Patrick, what's happening in Quebec?
Yeah, I think well, my contribution to the conversation was to give some sense as to how Quebec compares, or what are the early funding possibilities in the province of Quebec, and really Quebec is very different than the rest of Canada historically, where we see two distinct funding channels, and while we pay a lot of attention to the patient d'exception measure, and I'll give a bit more details on that. We need not forget about the funding channel for hospital medically necessary drug funding requests that are within the hospital setting, and that's also a separate measure that also serves a great purpose for patients, especially in the rare disease areas where many patients will obtain and have their drugs administered in the hospital setting. So with that said, there are kind of two distinct channels. The first one being the patient d'exception measure. It's been introduced almost 30 years back in Quebec. So there's a long-standing history where the government has deliberately decided to create funding opportunities from day zero at NOC under exceptional circumstances for patients that are treated in the community. And the funding requests are reviewed on a case-by-case basis. And while each request is not applied against a set criteria, so it's not a special odd program per se. The program itself, or the assessment of each patient, is done against a regulatory framework that has very specific criteria that are detailed in the regulatory framework, but are often not well understood by physicians or patients. And often there are missed opportunities where there's added delays in qualifying patients that are often being told no at first round, maybe told no at second round, and then eventually patients will get to some level of access. So when funding requests, the beauty of it is when the funding requests are actually accepted by RAMQ, the patient can simply walk into any pharmacy and then pick up the medication and move on with its way. And while it takes on average about 25 days for 80% of patients, and that's statistics from last year, 25 days is certainly better than 400 plus days in waiting for the LOI to be completed and for the provinces to finalize the agreement and actually add the product onto the formulary. So as far as, I mean, this creates a great avenue, but it is not perfect. It's certainly one where the government has struggled to maintain the existing measure. Why? Because in the last, like in the period of 2012 to 2017, the number of total patients that actually benefited from the program increased 56%. So kind of a lot of patients, and 30,000 plus patients in 2017. That numbers has escalated to close to just a little under 50,000 at this present moment. As far as are all requests accepted? We hear a lot of declines, especially in the rare disease area. Has this increased? When we look historically at the number of patients that are accepted and denied when presented with the patient d'exception, there's roughly about 25% of patients that get denied. So there's still a high level of acceptance, and despite the cost having escalated about 4 to 5 folds in the last 10 years, and are currently ranging in the $400 to $500 million per year for that program alone. So again, so is it perfect? No. Is it one that provides great access to a great number of patients? Yes. Is it a sizable commitment of government? Certainly. But but it is something that is again a government priority. And while there are some bumps in the road sometime from a government standpoint or from a patient or physician standpoint, all in all, the program is working, and bar none, the best program in the country. A little known fact or unknown fact is when patient exception requests are actually funded, it becomes a key driver as well for funding opportunities in the private sector, where typically a private insurer would call into RAMQ to understand if at least one patient has been funded. And that typically drives decision-making for exceptional access, even on high-cost rare disease medication. So it's something I'll take note. So the time is flying. So I'm briefly going to touch on the hospital medically necessary drug funding request. It's very similar in the mechanics as far as the patient exception request. So it's done, a request needs to be formulated by a physician. It's done on a case, it's evaluated on a case-by-case basis. There's no transparent criteria, so there's not a set criteria that the physician or the patient is working against to qualify a patient for funding. Not most requests, but a great proportion of requests end up being funded. I've heard a percentage depending on the specialty, but in oncology in the range of 70 to 80%. It still leaves 30% of patients in the dust. I wasn't able to uncover any specific details for rare disease, but I would imagine that it would be in a similar range. So what that creates, though, the same as, and it's more present in the hospital setting than with the patient exception that is centrally driven under RAMQ. There's more disparities. So we see and we hear about patients that often will nod their heads and with the best assistance of physician in a particular center and not get access, eventually will throw the towel in, secure funding opportunities, or will pursue opportunities in a separate center, and with sometimes some effort, sometimes they get access. So it just speaks to the disparity, which is unfortunate. And there's lots of energy wasted. So I'll stop there.
Thanks so much, Patrick. And just to let delegates know, a lot of people are still on the line. Thank you for that. I know we're over time. Our apologies, but a special thanks too to Karen and Bennett for being so patient. I hope we're not going to be too rude with your next meeting or whomever, but to let people know that if you have to sign off, this will be available for people who registered, so you'll be able to watch later. And we're just going to spend a few more minutes wrapping this panel up, and yeah, let's move over to Karen. And what do you think about that in terms of the insurance layer, and what is the private insurance industry doing to help make sure that, you know, Health Canada approval, that special team's done, passes it out, it's in one of your company's hands. What do you do with that puck?
Yeah, so thanks, Bill, and I'll be very brief on this because I know that we're very short on time, but private plans do have a variety of options that they use to help ensure access to drugs for rare disease for patients. So formulary management, prior authorization, unique tools and supports for patients with rare disease drugs like navigation to patient support programs and case management. And as you noted earlier, you know, there's also coordination that happens between the public plans and private plans, right? So depending on the provincial program, there is coordination in place, and it's well established because in a lot of cases we are sharing the patient, right? So you know, between the public and private plans, we do that integration to make sure that at the end of the day, the patient's obtaining the access that they need. The other thing that I would say is that, you know, whether, I mean, there are pros and cons to this, but private plans are not subject to CADTH and PCPA negotiations. And so, you know, to your point, once a drug gains approval through Health Canada, it's really, you know, at the insurer level, and at that point, they have the opportunity to really, you know, look at the medication and determine how it fits into each of the employer plans, because reminder to everybody, the plans are purchased by employers, so they will vary. But they have the opportunity, once that Health Canada approval happens to start looking at how that fits into each of the employer plans and develop the criteria for eligibility around that. So, because of that, it does get on private plans much sooner than it does on a public plan for various reasons, as I said. And so, in 2020, 13,000 patients roughly with rare disease medications gained access through those private plans, right? But having said all that, we know and we support the fact that things, need to change, right? To improve access and sustainability of the program over time. So, so one of those, that we fully support is development of a national formulary, so that there is equitable access. And I heard that in the first panel around the need for equitable access. And so, that national formulary, that whether you're a public plan or a private plan, would cover all of those medications on your plan. And of course, have the opportunity to cover more than that if an employer or a public plan decides they want to, but it would create some of that consistent equitable access for patients. And then beyond that, also that consistent clinical criteria that would be adopted both by public and private plans. And those are models that don't exist today, either in the private system or the public system. And so it would bring that consistent, equitable access to patients. And beyond that, the definition and inclusion criteria around, what is on a rare disease formulary. And I know that's been one of the questions along is, what's the scope of the problem and what fits on that formulary, right? And so, and then the national data system, rare disease registry, whatever that looks like, right? Critical to developing pay for performance or coverage arrangements. And I guess the last thing I would say is that, a big part of this comes down to being able to fund and sustain the program over time, right? And so, it is important to leverage the existing system that we have today. And in our submission to Health Canada, we included, a few funding options that would provide some of that cost sharing mechanism. Not to say that those are the models that we need to move forward with, but ones that we think, given the timeframes that we have in front of us and the urgency of the situation, that we could conceivably put into place in 2022. And so welcome the discussion from others around all of that as well. So I'm going to stop because I know we're really short on time and pass it back to you.
So encouraged by the forward-looking, constructive, let's figure it out approach that everyone is bringing. I'm actually surprised there's not more conflict, mainly around who's going to win the hockey game tonight, but also on some of these issues. I don't know, Bennett, what do you see from Sanofi's perspective in getting access to patients as soon as it comes out of the Biologics and Radiopharmaceuticals Directorate? How does it get into patients' arms or mouths in the best possible way?
Yes, for sure. Thank you for the invitation to be part of this panel. And I just want to thank all the previous speakers as well, and their stories and the courage to be able to share their stories to continue to move the needle and make things more available to patients who are in need. I just want to share a quick story about a compassionate program, and this is going back 20 years ago, and I'm going to call this individual John, who has a rare progressive disease, and he ended up being on mechanical ventilation. He was put on a newly approved drug by Health Canada, but it wasn't funded yet, and so it was a compassionate supply by Genzyme at the time. And he was able to come off mechanical ventilation for 90 minutes. And that was a miracle for him. And he said, this is great. I'm going to take this and advocate to my province, to any province to get this funded. And so, we went through the process. The patient went and told his stories and advocated, and eventually went through the whole review process. And the province came back and said, all right, we're going to fund this drug, but we're not going to fund it for John because he has mechanical ventilation, and he's not going to survive much longer given his disease state, and the value and benefit for this patient will not be realized. So as a company, it wouldn't be ethical for us to leave John hanging. I mean, it's great for all the other patients that were coming on board, but we provided a compassionate program for John. And fast forward 20 years later, And I just saw a picture of John yesterday in a story that was being shared. So I'm not doing justice to this story. And he had an infant child on his lap in a wheelchair. And I mean, that's a reminder of what it is that we do on a daily basis. You know, where you know, we have challenges in terms of getting access for patients. You know, as companies, you know, we try and do what we can. You know, we take on the risk early on from a clinical trial perspective to bring it to the Canadian market. And now we're seeing, you know, challenges at the HTA level. And this has already been spoken about how long it takes from Health Canada to get reimbursement, and it can take 2 years plus. And so as companies, we do have compassionate programs knowing that it would take that long, and we would provide that level of bridging for about two years approximately, with the anticipation that we'll get public reimbursement. But if that risk becomes higher in terms of achieving public reimbursement or getting any type of reimbursement, then it becomes more challenging for companies to make those decisions to come to the Canadian market and even to be able to bring a compassionate program. So this is the situation that we're at now, and I'm glad to hear of some of the changes that are being made at Health Canada to improve the regulatory timeframes. But from a you know, HTA and provincial timeframe, I would love to see rolling submissions and rolling data, because we all know that when we have a clinical trial that's completed for rare diseases, it's not going to answer all the questions that the payer will have. And so, you know, one of the schemes that have been utilized in the past is a partnership with industry and provincial payers for real world data collection. And so there's been one that has been successful in the past because we don't have all that data, but we're willing to partner with the provinces. But we need to see more of that as well. The acceptance that, okay, the data is as good as we have it here, but let's think of a way that we can bridge that gap. And so, you know, one way is through compassionate program. Another way is through a clinical trial program, and to provide therapies to patients even prior to reimbursement. But one note on clinical trial programs as well is it's going to become more challenging to even have clinical trials here in Canada, because clinical trials is also based on standard of care. And if the standard of care is not equivalent here in Canada versus other countries, then companies and clinical trial directors will have to decide which jurisdiction is best to run those clinical trials. So I know we're running out of time, and I'm just going to keep my message here short and end it here if there's any further questions.
Thanks so much, Bennett. Durhan, do you want to help sort of close it out? I know we're way over time. So, and thank you to my panel. If I'm going to log off or mute right now, Durhan, why don't you take us home, and we'll see you all soon, hopefully in person. Let's get through this pandemic business, okay?
Well, it isn't for any lack of trying on everyone's part. So my huge apologies to everyone. This has been my fault for having such an amazing panel to start off with. There was no way that we could cut off people. And I really thank this second panel for not only hanging in there, but bringing such amazing messages forward. I'm reading some of the comments, and certainly huge kudos to everybody. But also some sobering thoughts. Next week, we are going to do manage access with real world evidence. This discussion will get picked up and rolled into there. And even more so, the 2 weeks from now, we're going to be talking about how do we bring more drugs into Canada in a timely fashion? What is it that Canada needs? So Bennett, you know, you've given us some fair warning and probably have sort of put your head up enough that we're probably going to lure you back in. So there you be for being so great. And it's same with Patrick and Brad. So I think we've set ourselves up to have some amazing panels even before we go there. And then finally, as I said, the last one, and again, everybody talked about it, we need the infrastructure. We need to have the ability to be able to use these drugs in the most effective way. And we've got to talk about that. So I begin to feel a little bit like, you know, Joe Biden talking about infrastructure, where infrastructure is not a bridge, it's not a building. We're really talking about, a healthcare infrastructure that's going to be essential in terms of being able to make sure that we make the best use of drugs. So this is an amazing discussion. You're amazing. The 70 participants, they're still on. You guys are amazing. So kudos to all of you for hanging in there with us. And we will definitely have it recorded. You don't need to hear this. The people that have left are the ones that we need to get the message out to, that this will be available. Many, many thanks to all of these panelists. What a great discussion. And also my huge thanks to Celia. Some of the comments that were in here were really pertinent. And that is, a lot of times we hear over again, it's really, the fact that we're not getting drugs faster and we're not getting drugs approved is not Health Canada's fault. They're really moving mountains in terms of keeping up to date. And I'm looking forward to that 3D organ that Health Canada is going to approve for us. So best to everybody. I've seen some of the genetic therapies as well, where they're taking genes from mice and being able to clone human organs from them. So I'm waiting for Health Canada to put their regulatory process into place for that as well. So thanks to everybody. And we will have the recordings, and we will hopefully see all of you next week. Thank you.